So we'll start the today's topic. It is on deep venous thrombosis and pulmonary embolism. The current evidences for imaging approach. So regarding acute venous thromboembolism, the epidemiology of the acute venous thromboembolism is around 50 per lakh per year. 10% of all acute PEs die within first 3 months. So it is extremely important that you diagnose these patients and they will get the proper treatment. Regarding the Indian autopsy series, the incidence is 15%, mainly in those who are below 50. So according to the age, also according to the symptomatology, also you have to diagnose these patients. And the PE contribution to the death is around 12%. So if you see the autopsy series, among those autopsy series, 12% patients will have venous thromboembolism that is leading up to pulmonary embolism. 20% of all venous thromboembolisms are cancer related. So it is around 1/5 of the total venous thromboembolisms are because of cancer. Surgery and immobilization both account for 15%. So even we both combine it, cancer has a significant chance that they will have the venous thromboembolism. About 70% of these patients will have symptomatic PE. Okay? And those who have symptomatic PE have concomitant deep venous thrombosis. So if you see a scan in which there is a pulmonary thromboembolism, if you do an ultrasound, you will find 70% of them will have DVTs. Silent PEs can be there in around third of the patient with symptomatic DVT. So if you reverse the situation in which you have a symptomatic DVT, and if you do a chest imaging, around in 1/3 of the patients you will find silent pulmonary embolism that are not symptomatic. These patients are not symptomatic, so they can become symptomatic. So imaging vice versa is important. Okay. The thing is that regarding diagnostic investigations, which we will choose, so the signs and symptoms that are related to pulmonary embolism are non-specific. It's not like DVT that there is a swelling of the limb and you have a lot of pitting edema, there is a tenderness and all those conditions. PE can be poorly specified. There can be mild tachycardia, mild tachypnea, all those kind of, there can be dyspnea, but it is not leading to the diagnosis of pulmonary embolism. So we have to identify these patients because these are very acute, okay, and we have to rapidly identify. So which patient will undergo treatment, which will not undergo treatment, that will depend upon your imaging. So if you correctly identify, then you can prevent the thrombus, it is being extended. If you cannot identify, then these patients in which you falsely label them, it is an unnecessary diagnostic test and the patient will be on anticoagulant and the lifelong therapy. So it is a great challenge actually. Everything will depend upon what you write. If you write down there is a thrombus, the patient will be on lifelong anticoagulant. If you don't write down and the patient having thrombus, it might be devastating for the patient. So you have to actually correctly identify these kind of patients. So before going into this thing, what kind of imaging we should do? We should have a clinical probability pretest. Okay. So which patient might have a probability of pulmonary thromboembolism? Okay. So that will depend upon the clinical criteria and the D-dimer testing. Okay. What we do in the imaging is the compression ultrasonography that everyone is doing it in a day in and out. And the compression sonography will have a false negative rate of below 1%. So if you are good at it, then the chance that you will miss embolus is less than 1%. Okay, out of 100 patients, in one patient you might be losing the thrombus. So that is acceptable. Okay. So pelvic and inferior cable thrombosis can be challenging with their compression sonography. Why? Because the patients might be having obese and there can be a lot of fat that might be difficult. There can be bowel gas and the compression might be difficult. Now, all those things that will lead up to more false negatives in case of pelvic ultrasounds. Okay. So if you want to image the external iliacs, internal iliacs and IVC, all these, the chances are that you can miss the thrombus. So if you are not finding it out there and if the D-dimer is coming positive, then you will screen for the other modality. Okay. So in that case, it can be CT or MR venography to exclude, if you want to exclude what is the cause of the elevated D-dimer. So D-dimers can be elevated because of the sepsis, infection, immobilization and all those conditions. But if the D dimer is negative, then you are pretty sure that if you don't do imaging also, then there is no harm to the patient, because the patient will not have pulmonary embolism, which is significant clinically. So these are the clinical decisions that we are taking it. So there are two systems that has been designed. One is the Wells score and another is the Geneva scoring system. So one is for DVT and another is for PE. So Wells is both for DVT and PE, and Geneva is for PE. So what are the things? There is history of cancer, so that is the active cancer. There is history of immobilizations. Okay, immobilization is more than 3 days, major surgeries. The patient is having local tenderness in the deep venous system, swelling of the entire leg, calf swelling that is more than 3 centimeter. There is a pitting edema. There are superficial venous collaterals, and there is an alternative diagnosis. If there is an alternative diagnosis, everything will go into the negative. So you are not dealing with the DVT. But among all those things, if it is there, then you put up these points and then see the score where it is lying. So DVT is unlikely if the score is less than 2. Even the patient is having, suppose there is an active history of cancer and there is a swelling of the leg and there is no other findings, then there might be a possibility that you are not having the DVTs. Okay. If the class and similarly for the revised Geneva scoring, the probability of having PE is less than 4 if the point system is less than 4. It is more if the point system is more than 4. So going to the pulmonary thromboembolism. So what we do for this thing, for the pulmonary veins, we will do the Valsalva maneuvers. So that will tell what it will tell. Has anybody done it? Augmentation and the Valsalva maneuvers. So if you do Valsalva maneuver, what will happen? There. So you put in pulse wave Doppler, you do a Valsalva, and you have to see the phasicity. So if you see the venous system, there is a phasicity. It is a monophasic, but still there is an undulating line that is coming up and down, up and down, up and down a little bit, but it's not crossing the baseline on the opposite side. So that's why how you differentiate whether it's a venous or it is an arterial. So arterial, if you will see there is a line that is coming down and again coming up. So that is a triphasic one. So it is a monophasic one, but still because of the respiratory system there is a phasicity because it is increasing along with the respiration. So that is inspiration, expiration, inspiration. So that phasicity is maintained. So if you do Valsalva, there is a complete obliteration of the phasicity. The flow will stop, and suddenly you do the augmentation. So because of this, proximal extent we can know. So still, if it is not having that phasicity, so then we get to know that there is something abnormal in the proximal system. Okay. So if it is like monophasic, okay, but there is no undulating line, and it is a very slow flow, then there is a probability that we are having significant embolus in the proximal venous system. And if there is a similar augmentation, when we are giving augmentation, it will not rise, then we are having distal embolus. So at one point of time, if you put this, then you will get to know whether there is anything proximal to this or distal to this. Okay. Whether we do augmentation or not, it is a debatable criteria, because people are saying that if you do augmentation, there might be a chance that it will dislodge and it will go into the pulmonary arterial system. So, but when they have done the series and in which they haven't found any, if you do augmentation, there is no clinically significant dislodging of the embolus as compared to the non-augmentation ultrasounds. So that is one system. So we are going to the, I have some images. I will take one DVT lecture next time. So pulmonary thromboembolism can be acute and it can be chronic. Okay. So what are the things that you will see in the acute chronic thromboembolism? Acute pulmonary thromboembolism. And
the angle of the throat, and it's the polo sign.
okay.
You can see right half screen.
So I am going through this thing when we should do the imaging. So actually these are all the symptoms that are non-specific, and you see the pretext probabilities, and then you have to do the early risk stratification. So clinical, there is some inputs. So that is if the systolic blood pressure is less than 90, and remain for more than 50 minutes, there is pulselessness, their heart rate is below this, and patient is in shock, and the suspected PE is very high, you do the imaging without any D-dimer. Patients directly go into the department, and if the patient is able to shift, then you do the MDCT angio, okay, and if it is unable to shift, then you do the echo at the bed itself. So whether there is any right heart strain, you stabilize the patient, and then if you want to do the imaging, you can do it, or either you can directly, if there are significant findings on the imaging, then you directly treat it for PE. If on echo you find some other cause, then okay, treat about that cause. In MDCT, you see the thrombus, you will treat it. If all the symptoms are there and the probability of having PE is less, all those clinical symptoms, but still there is a probability less, then you do the D-dimer. So if the D-dimer comes negative, then the chance that the patient will have pulmonary embolism is less than 1%. Okay. If the pretext probability is, so this is older system, in the newer one it is more than 4. Okay. So if that is more than 4, then the chance the patient will have pulmonary embolism is high. You do a MDCT. If it comes positive, you will treat it. If it is negative, then stop it.
Yes, patients, you get those cancer patients, they say that they don't need D-dimer, even though they are not, VPNL is okay,
So
just one tachycardia. Is that correct, or should they do D-dimer?
So I have put one slide actually. The thing is that we have analyzed around 1,000 pulmonary, 100 pulmonary angiographies. Out of them, only 22 had D-dimer. Okay. So among those who have D-dimer, it is around 13 will have positive D-dimers. Among these, 6 are positive because of some kind of infection, pneumonitis, sepsis, or whatever it is. But once it was negative, it is around 9 patients. None of had pulmonary embolism. Okay. So we have to actually collect more data, and then we'll try to project them. That if there is a no D-dimer, then just don't send it for pulmonary angiography. But another thing is that the alternative diagnosis that had, so around 25 patients have pleural effusion and pericardial effusion. 8 had disease progression. 9 had around drug-induced toxicity. So all those will need CT, especially that this pleural effusion will not need CT. Otherwise, drug-induced toxicity, disease progression, and all those, they might not need angiography, but still they need a CT. So the alternative diagnosis was around in 40%. So out of them, 40% have some or other kind of symptomatology on the scan. What will you do once a clinical cause has been made to investigate a patient that is suspected for pulmonary embolism? So these are the modalities we are having in our department. X-ray is there, CT is there, MR is there, PET CT we are not having, but usually call it. So X-rays. So the main role of X-ray is to rule out other possibilities that may mimic or simulate pulmonary thromboembolism. So the patient might be having large pleural effusion, patient might be having large consolidation, and all those things are there actually. So you don't want to subject everyone to the pulmonary angiography. You have to triage your patients, see them, if there is another probable diagnosis that is possible on that. Not every patient will go under this thing. Then we go to the CT angiography. Okay. So I don't know what protocol we are using for PA. So it is around 60 to 80 ml of contrast we should use, but see the viscosity will be around 370 nanogram per ml, but contrast we are using it. Injection rate is 5 ml per second. Okay. So this is the good quality scan. Okay. You should have this kind of optimal contrast of opacification in the pulmonary arteries.
Some people say SEC.
You will place in the pulmonary conus. Pulmonary conus. So if you want to evaluate the patient for chest pain, so then you want both arterial and pulmonary aortic as well as pulmonary artery phase. But if you only want to see for pulmonary embolism, then you have to put on the pulmonary conus. Because the chest pain can be because of varied things. It can be because of dissection of the aorta, there is aortic aneurysm, there can be another thing, there can be coronary this thing. So there can be so many causes. So if that you want to evaluate, then you have to do for both pulmonary artery as well as aorta. If you are only suspecting PE, then you have to put in the pulmonary conus. So you want to opacify, because if it is the contrast opacification is not that much, you will miss many of these small embolus, though they may not be clinically significant, but still. So typically you will see this. So it is non-enhancing, bland. If it is larger, it can expand the artery. If it is smaller, then it will either may hang in the artery, or there may be an acute angle with the artery. So these are the things that you see in the acute this thing. So if you see, there can be Philip defect. So directly you can see a thrombus. Okay, and these are them. Okay, so first here I think you can see. So there is a rim of the contrast that is surrounding here, and then there's a non-enhancing bland thrombus within it. So these are the large thrombi. These are the acute ones. Okay, so they are symmetrically parallel. So not necessarily that you will see a parallel line like this, like this. It can be here, it can be here, it can be here. So all these are telemetric signs. This is the saddle thrombus. It is in the both the arteries, going into the main pulmonary artery. And this can be plaque-like. Usually these kind of things are seen in the chronic PEs. Okay? They are very fibrotic, and they are in the periphery. They are maintaining obtuse angles and all those things. But you still, if it is very subtle one, you can see in the acute also. So these are the direct signs. So what are the indirect signs that we are seeing on the imaging? So basically on the chest window. So when we had seen the mediastinal window, these are the direct signs. We can directly visualize there is a thrombus. So what are the things that will help you? If this is there, then you try to search for the thrombus in the proximal artery. How will you identify oligemia on chest?
Mosaic and infarction.
So mosaic will come into the chronic phase. So what are the things that will come into the acute phase? Infarct.
And pleural effusion.
Okay. Lesions will be relatively later.
Bubble.
So bubble will be like this kind of bubble you will see in both adenocarcinomas and this one. You can see this bubble sign. So there are wedge-shaped opacities are there. You can have bubbly lucencies. Bubble is like something which, if you do over the time imaging, it will shrink at its position. So it's like ice that is melting without changing its shape. And there can be cavitation. So if it is too acute and it is too large, it is completely obliterated the pulmonary artery, then it can undergo necrosis. Okay. So if you see this thing, infarctions, and you try to image this area, then you can see the thrombus in the artery, and then subsequently there is a pulmonary infarctions, publications. Okay, and these are the cavitations. So that we are not doing it routinely because we are not suspecting into the venous system. So when we are doing it, what is the sensitivity and specificity? So whether which test is gold standard, and whether we can identify these disease in the very early phase, which is a clinically relevant one or a clinically significant one. Okay. So if you see the sensitivity, it is approaches 100%. If it is central one, I'm not talking about peripheral, because I think nobody is caring about peripheral ones. People are only reporting central ones, most of them, because peripheral embolus are missed. It's good to the patient, but otherwise what will happen, they have to remain on the lifelong anticoagulant therapy. But we have to see also what is the load into the deep venous system also. If there is a high load in the deep venous system, then they will require anticoagulation. Once you detect a thrombus, it will undergo a lifelong anticoagulant therapy. So we have analyzed some this thing. If we have seen the majority of the patients, say 22 patients out of 100 had DVT. Among that, 17 patients has adenocarcinoma. So if there is a adenocarcinoma, it can be of anything. It can be of breast origin, it can be lung origin, it can be ovarian origin, or it can be papillary, whatever it is. The chances that they will harbor deep venous thrombi is very high. You will pick up most of the time you are picking up silent thromboembolism also. In lung, I think you might have reported that the patient is coming, is doing scan, and there is a large thrombus sitting into the pulmonary artery. So these are the probabilities we are having it. So central region, we are very good. We are very good in picking up these central areas. Peripheral, the specificity or sensitivity will drop down. Half of you or me will able to detect the peripheral thrombemboli. So specificity. So if you pick up a thrombus, you will label it as a thrombus is also very high. So I don't see if you are picking up something which is hypodense in the membrane of the artery, you are calling it something else. You will call it as a thrombus. So the specificity also 100%. Again, if there is something that is streak that is seen in the peripheral, whether you call it as a thromboembolism and doubt. So both sense picking up and calling it as thromboembolism, both are less. So you will see these typical these things. We have seen the subsegmental. So I think we will miss them if the imaging is not good. Okay, this is picked up because there is an infection that is happening into the lower lobe. So that's why you want to see whether there is something there in the. So the other thing. So the higher the pretest probability. So if the D dimer is positive, the patient is on clinical symptoms, pretest probability is high, then whatever you will label it as, it is a, you see is a thrombus. If the pretest probability is low and the symptomatology is not getting into it, then what you are seeing is actually a thrombus or something else. Because if you label it as a thrombus, then it is on anticoagulant therapy. There might be something else also. So in that scenario, you are more important. Everybody can pick up the acute pulmonary thromboemboli. But if you pick up the acute pulmonary thromboemboli, what you will do next? That is also more important. Okay. So CT will help you in regarding understanding of the disease. So what is the extent of the disease that you are seeing? Whether it is a high risk category, it is an intermediate risk, or it is a low risk. Okay. So it will help you in prognosticating the patients. So if there is a large saddle thrombus, the probability of having surviving is very, very low. Whatever you will do, it will die within 3, 4, 5 months of time, or maybe in some few days or few hours. Second thing is that we want to pick up the RV dysfunction. Okay. So RV dysfunction, how will you get to know whether the right ventricle dysfunction is there or not?
Ventricular wall goes to symptom.
So there is a subtle bounce. So subtle bounce is a term that is used in MR when you do scene images. But if there is a septum and that is more towards the left ventricle, either it is straight or it's going towards left ventricle, then it is the abnormal one. It is usually towards the right ventricle. Then you do the ratios. So septal bounce, it will depend upon your sensitivity of picking it. But if you try to measure in all these patients, so whether the ratio is more than 9, then you are dealing with an RV strain or maybe an RV dysfunction. Okay, so these are the direct measurements. So these are some indirect measurements that will tell that the patient is having RV dysfunction is that there is a dilatation of RA or RV, and there is a regradation of the contrast into the hepatic veins or IDCs and all those things. Okay. So you can see this that we have measured it. So the ratio is coming this. This is the IVC reflex. Then comes the dual energy. So we are not having it, might be having after some time. So I think it is on under process, so we might get it. So it is better for the peripheral emboli. So where the CT will get low, DCT will have a good role. So because if the patient is symptomatic and we are not picking up, then at that time I think it is a very, very good role. So it will allow differentiation between the acute and the chronic one. Okay. And quantification of the blood volume. So there are so many softwares are there along with this thing, dual energy. Then you can actually quantify whether similarly like that what we are doing in the nuclear medicine. Whether it is oligemic area, this is not usually not, because that will depend upon the iodinated contrast that we are extracting the information. So it is because of dual energy that we are able to extract it. Otherwise it is difficult. So usually, even if you don't give contrast also, even if you give less contrast also, you will get it non-contrast. I'm sorry, but if you give less contrast, because it will depend upon the atomic number of the iodine. So wherever there is less iodine, it will pick it up. So you can see this thing. There is a saddle thrombus, and these are the areas. Okay. So whatever it is black, it is the polyemia. The iodine concentration is very less. So these are the perfusion defects. So what you have seen in the VQ scanning, ventilation and perfusion scans, these are the perfusion defects. So actually we want to see only the perfusion defects. You don't want to see the ventilation. So earlier it is because they are doing it ventilation, they have to incorporate each and every VQ scan with the chest X-ray. Okay, the chest X-ray is having consolidation, and then there is a ventilation. It should have ventilation defect. Okay. If there is nothing on the chest X-ray and then there is a perfusion defect, then it is a pulmonary embolism. So there is these kind of things we have to do earlier, but now almost nuclear medicine has no role in pulmonary thromboembolism. So there can be non-thrombotic pulmonary embolism. What are the causes? Thrombus, something which is there in the artery, not always necessary to be blend thrombus. Septic emboli.
Amniotic.
How will you know whether it is septic emboli?
Intravenous drug.
Huh?
IV drug.
I will tell you this.
You have cavitated multiple regions in the lungs.
Imaging is different one, huh?
Lungs.
Whether it is having AR or whether it is having stranding, is attached to the artery, there is a mycotic aneurysms and all those. If they are there, then you can label it. Otherwise, if there is no history of this thing, infection or infective endocarditis, I think it is very difficult whether we label it as an infective thromboemboli. So these will have unusual morphologies apart from this thing, enhancement. So when we are talking about non-thrombotic, usually we are talking about whether it is malignancy or not. Okay. So there is an enhancement in this thing. There can be unusual findings in the lung, and patient will most of the time have malignancy. Patient might be having lung cancer, breast cancer, or all those things. So if you see this, so there is a thrombus on that side, and if you see there is a mass-like picture on this side. Okay, and then this is the patient. This is having. So you can see there is a mass in the pulmonary conus extending to the right pulmonary artery, and then these are the wedge-shaped areas that are not enhancing, and there is associated effusion and all those conditions. So you can see this thing. There is a mass here. Okay, that is not enhancing. So actually, you have to identify areas. So C is not happy because C is not able to see the enhancement. So actually you have to put your HU values. So how much is the difference in the pre and the post? Then you will get to know whether it is enhancing or not. Otherwise it is difficult. So you put an HU values. Next time you are seeing this kind of image, whether it is enhancing or not, whether it is a blend one or not. Okay. So is there any role of MRI? Somebody asked me, we don't want CT and we only want MRI.
Chronic.
Huh?
Chronic.
Chronic pulmonary thromboembolism.
Can quantify heart function.
Intracardiac
Intercardiac thrombus. Got it. What?
CT pulmonary contract or relatively contract. Pregnancy.
Pregnancy. Right.
Similarly.
So the thing is that how many people can able to do the angiography? How many of you will able to do the angiography in the MRI? Technically it is difficult to get a good MRI angiography view. So we have the options of non-contrast in images. Now every time we don't have to give contrast if we want to see the major vessels and the heart. So we have that option with us. The sensitivity it is and specificity is lower. Interpretation of MRI is still a problem among the radiologists also. Okay? And there is a high rate of technically unsuccessful studies. So there is a high rate of technically unsuccessful studies. So MRI, if you do, It will most of the time is referred to something else, and you pick up the unexplained pulmonary hypertension and all those kind of things. So these are the things we are doing it. Okay. So you can see there is a non-enhancing gland thrombus now, but see the amount, the clarity of the images is not as great as the CT. If there is any role of PET CT. So few of the images are of SIR actually, the primary sarcomas, that they will light up on the PET CT. Gland thrombus will not light up. Okay. So if you want to see this, it's the contrast enhancing one, and on the PET is lighting up. So if you want to differentiate, sometime when you are not able to differentiate on the CT, you might have to do PET CT. There is a very, very high index of suspicion of malignancy, and that is not characterizable on the CT. That is the only condition. Otherwise, it is absolutely there is no indication for PET CT. Chronic one. Sorry. What are the findings we see in the chronic PE? And why it is important also. We are missing all chronic PEs. 90% of them. We are having a very high incidence of this pulmonary thromboembolism, that is acute one. But when they are coming for the follow-up, we are missing completely. 90% of them, we are missing it. So basically, everything will become fibrotic. The vessels that we are seeing it, they will become atrophied, they will become cord-like. The bronchi that are there, they will start getting dilated. So if there is an unexplained dilatation of the bronchi and there is a trimming of the or pruning of the vessels in the same area, then you know that this patient had earlier embolic episode. Now this is the sequelae of this thing. And if it is involving too large of the volume of the lung, then the patient will be having pulmonary hypertension that is chronic in nature. So these are the things, and that can eventually lead up to all those things that we are seeing in the acute lung. Then there is an RV strain, dilatation of RA, RV, and all those reflex phenomena and everything. But you have to identify it. So we are missing it, in our reports. And so it is not related only to the lung. Whether it's a breast, whether it is an GI or whatever it is, we are missing it. So the non-resolving, the incidence, if you see the prevalence of this thing, is around 10%. So if there are 100 patients, they are coming on the follow-up, 10% will have the residual disease, at least. Okay. So mosaic perfusion that we are seeing it. Okay. So you can see there is a pruning of the vessels in the area where there is a more dark areas and all those things. Then that is the area where it is the abnormality, not that is the area where it is white. So there is a differential this thing. Okay. If it is something related to the bronchus, then what? So that is the area where it is abnormal. There is a tracking of the disease. So actually, you have to identify whether it is related to the bronchi or whether it is related to the vessels. So that's how. So if you see this kind of pattern, try to see how is the vessel in the dark areas and how is the bronchus. So both things will help you in identifying which kind of things we are dealing with. Then there are abnormality findings that we are not doing it. So we are not doing it, the pulmonary angiographies for these things. For the chronic ones, we are only doing the chest CTs. Okay. So you can see these mosaic areas, and if this patient had all those things. Okay. And then there are webs and stenosis and all those conditions when you do follow-up. Signs of PH we have already discussed, so I'm not going about it. Perfusion defects that we have already seen. Okay. Everybody can diagnose acute, everybody can diagnose chronic, and everybody can tell whether it is because of gland thrombus or it is because of tumor thrombus, and whether there is any associated abnormality that you have to see because of these thromboemboli, whether it's of direct signs or whether it's of indirect signs. Okay. So CT, you will tell whether it is in severity index. We can tell it. And what is the use of other modalities?